To start us on this journey, we are honored to have as our inaugural keynote speaker Senator Tom Daschle. For a generation, through his 8 years as a congressman, 18 years as a senator, including 2 as Senate Majority Leader, Senator Daschle has participated in the development and debate of nearly every major public policy issue. His dedication to improving the health and health care of Americans has been steadfast. His 2008 book, Critical: What We Can Do About the Healthcare Crisis, lay out a comprehensive plan for improving our healthcare system, many elements of which have been implemented. Over the past year, Senator Daschle has chaired the Center for American Progress, co-founded the Bipartisan Policy Center, and co-founded the Alliance for Connected Care to enable Americans to receive care remotely. Currently, Senator Daschle serves on the board of Doctor on Demand and is the CEO of the Daschle Group, a full-service strategic advisory firm that advises clients on a broad array of economic, policy, and political issues. On a personal level, Senator Daschle is a kind and generous man who makes time for all, even academic neurologists. We are very fortunate and honored to have him as our keynote speaker. Senator Daschle.
Ray, thank you very much for that very kind introduction. And thank you both, Ray and Avi, for putting this enormously successful summit together, the first annual. I am very, very grateful to be a part of it and appreciate very much the opportunity to be here this morning. And let me thank the New York Academy of Sciences for the incredible venue. As a South Dakotan, I'm just breathtaking. I can't fully appreciate the magnitude of the view. It'll be hard for me to concentrate on my remarks, given the view that I have as I look out these windows. I really appreciate Ray's kind words. In politics and in the business of legislating, you get introduced in a lot of different ways. One of my most memorable introductions occurred much like you just heard this morning. But the man who introduced me used the word model frequently. He said, Daschle is a model politician and a model South Dakotan and a model legislator. One of my staff showed me the word model later on that day as it's defined in the dictionary, and there it's defined as a small replica of the real thing. I listened carefully, and Ray didn't use that word, and I appreciate it very much. But I am a card-carrying baby boomer and an aging American, so I have a personal interest in this agenda. And let me say, I think I speak for almost all baby boomers in expressing to those of you who have dedicated your lives to health and improving the quality of health for all Americans how grateful we are. Many of us are very blessed to enjoy good health. And in large measure, it's directly related to the research, the effort, the leadership, and the commitment that you all have made. And so for that, I know I can speak for baby boomers in expressing our gratitude. This year, as most of you know, we celebrate the 50th anniversary of the passage, the enactment of Medicare. Prior to 1965, fewer than half of all Americans over the age of 65 had health insurance. That in part was due to the fact that most of them had pre-existing conditions and couldn't purchase it even if they wanted to. And for those that did, premiums were sometimes 3 to 4 times what they were for younger people. That all changed 50 years ago. And today, over 95% of all seniors, all those over the age of 65, have health insurance. A remarkable accomplishment. There have been 2 pivotal events in the last 50 years, primarily in the last 18, that have had a consequential effect on the Medicare program. You all are familiar with these events. The first occurred in 1997, when for the first time Congress authorized legislation to provide for the access to commercial health insurance, so-called Part C. And today, 30% of Medicare beneficiaries are enrolled in Part C plans. In 2003, Congress passed a monumental piece of legislation that allowed for the first time beneficiaries to access prescription drugs on an outpatient basis. now called Part D. Over 80% of Medicare beneficiaries today access the Part D program. So as we look back over this last half century, I think the most consequential driver of all of this change has really been the transformation we've seen in policy, as I've just described, as well as technology. Those drivers have created new opportunities for access and quality that we couldn't have imagined 50 years ago. And yet, as we assess our circumstances now in 2015, I think it's fair to say that there are a number of notable challenges that we are going to have to face as we address health care for the aging going forward. And Ray mentioned one of them in the introduction. Demographics. We are going to move in a short period of time, the next 10 years, from about 54 million Medicare beneficiaries to over 70 in 2025. That presents enormous challenges. The second challenge has to do with chronic illness. Experts predict that by 2020, 1 out of every 2 Americans will have a chronic illness. But you think that is astounding? 85% of those over the age of 65 have at least one today. And it generates enough of a demand on the budget to exceed 78% of the entire amount we spend on Medicare. So we have challenges in those two contexts that can't be ignored. But we also have challenges that go beyond just the numbers. Geographic challenges. A significant number of our seniors live in rural and isolated areas where physicians generally don't. So even if they have insurance, their access to care is limited. And finally, we have to recognize that we have a cost problem. We've benefited substantially over the last few years from the cost containment efforts that have been enacted and have been utilized in various ways. We're now at the lowest cost growth in Medicare that we've been in all of our 50-year history. In fact, we're at a $1,000 per beneficiary lower rate of cost growth than we thought we would be in 2010. So we've made some progress. But as all experts look at the next 10 years, we expect cost growth in Medicare to grow by 2/3, from about $512 billion today to $858 billion by 2025. So as we look at these challenges, we've got to hope that those transformational forces, policy and technology, can really have a profound effect in giving us answers to the solutions and solutions to the challenges that we face that I've just outlined and many that I haven't. And I have no doubt that as we look at big data, as we look at the digital and electronic capacity that we've now been able to acquire over these last 15 years in particular, that the transformational effect of these technological revolutions will have a profound effect on our ability to address many of these issues going forward. Electronic health records could easily be the central source of information for patients and providers and payers going forward. More technology means greater transparency for price and quality. It means better access to evidence-based approaches to medicine. Integrated health will give us more of an opportunity to personalize care with genetics and genomics and the opportunity for precision medicine that we never thought possible just 10 years ago. As I look at the next few years, one of the concerns I think most of us have as we look to both geographic and demographic consequences is that it's likely, if you believe the experts, that 20% of our hospitals will probably close in the next 10 years. They'll be rural, they'll be isolated. But that alone presents a very serious challenge for us as well. Most of these hospitals will be ones that fail to achieve critical mass. But as these hospitals do close, the demand for disruptive new models of care will be absolutely essential. And so as we look at these disruptive models, we can take some solace in knowing that already technology is providing many of these opportunities. And as we consider some of them, they offer great promise. Hospitals at home provide opportunities for acute care in home health settings that have some commonality to them. We have virtual care, or as Ray and I like to describe it, as the return of the house call. Virtual visits available 24 hours a day, 7 days a week. Opportunities to access care and address some of the geographic disparities that I've mentioned in my comments so far. The recognition that virtual care can be provided in ways that we never thought possible just a few years ago is becoming more and more the reality. Two large care entities, Kaiser and the Veterans Administration, one private and one public, have already made great advances in adopting and expanding virtual visits today. So the technological opportunities are there. The technological applications to address many of the challenges we face as we look at the many problems that we could experience in Medicare going forward are there. I think the real question is whether we can count on policy being just as transformational as we look to the next several years. Because we're going to need a policy infrastructure that accommodates this new technology. And therein lies one of the major questions. Will we have the policy capacity to produce the kind of opportunities that technology presents today? I think Secretary Burwell understands that. I think she's done a good job in beginning to put the Department of Health and Human Services on a track to accommodate these policy demands. And she's done it largely in three contexts. The first context is insurance reform, and a recognition that if we're going to be serious in addressing these changes and this migration away from the way we have looked at care in the past as largely an illness system, if we're going to create a wellness system, we need to compensate, and we need to ensure that our policies reflect a new priority for preventative care and wellness, for mental and population health, and coverage for those kinds of services need to be established. Insurance reform. We also have a need for meaningful payment reform, and she's moved us in the direction away from fee-for-service, migrating to risk and value-based insurance models. So critical as we look to the future, and at an accelerated rate. By 2018, a significant portion of all care delivered for Medicare will be risk and value-based. The third is delivery reform, and a recognition that we have to change the concepts of delivery, organizationally with ACOs and perhaps medical homes, a greater emphasis on evidence-based health, a recognition that we need better qualitative measures than we have today, and a realization that the road to interoperability is essential if we're going to do any of this. And so we look at insurance, payment, and delivery reform as sort of the initial stages in this policy formulation that could make a huge difference as we look at the technological applications that are out there already. The CMS actually has made somewhat of a consequential contribution to this whole question of reimbursement of telehealth and virtual visit services last fall, and I would call it a start. And that's all it really is a start. It's an experimentation. It's an opportunity to look to see whether we can find ways to expand it. Because as I look at all the policy impediments for telehealth and virtual visits today at the federal level, none compare to the importance of reimbursement for those services in both Medicare and Medicaid. We have a lot of work to do. The same could be said for state licensing. As probably everybody in this room fully appreciates, a physician has to be licensed in the state where the patient is located. And while there may have been good reason for that, we need to move beyond, because that requirement is outdated and counterproductive. The new opportunities for states to work together in compacts is a beginning, is an opportunity for us to move forward on that side as well. But if we're ultimately going to accomplish what we need to, we're going to have legislative support at the federal and state level to achieve all that we must with regard to both licensing and reimbursement. My hope, as we look to the challenges we face going forward, is that we can appreciate several realizations. As we look to the next 50 years, it would seem to me that we could be absolutely certain that Americans are going to live longer, grow older, and experience more chronic illness. We can also assume that the transformational forces that we've seen in technology and policy are very likely to continue and have an equally transformational effect as we go forward. And the third is that while our goal over these past 50 years to achieve a high-performance, high-value healthcare marketplace with better access, better quality, and lower cost, that goal probably doesn't have to change much as we look to the next 50 years. But what does have to change is the means by which we achieve it. Technology and policy will be essential. I would also add that I think policymakers are going to have to address some of the concerns that have been very problematic, both politically and legislatively, in the last 50 years. The quality and the financing of long-term care, innovative approaches to the palliative care that is now slowly evolving and becoming more widely recognized as an important vehicle, and certainly all of the issues that confront us as we look at the end of life. Those issues in the past have been largely ignored, and they can't be ignored any longer. We need to address them. So as I think of the next challenges that we face, as we look at the next 50 years, it really comes down to leadership, and that's really what this summit's all about. It's bringing leaders together, like-minded, determined to address these many challenges we face. And it seems to me that the 4 pillars of leadership that I've always applied would certainly apply here. If we're going to rise to the level of leadership required to be successful, we're going to need to be, number one, resilient. There will be setbacks. There are going to be a lot of unexpected developments, just as there has been in the last 50. Can we pick ourselves up and continue to strive to achieve our goals in spite of the setbacks? Resiliency is critical. Second, innovation. Our country has long been known as the most innovative place in the world. Can we continue to apply that innovative skill and character to the challenges we face in health, especially with regard to aging? Third is collaboration. There is one thing that I would argue characterizes our health system that troubles me greatly, and that's how siloed we continue to be. We need more collaboration, and we will not achieve our level of leadership without it. And finally, and fourth, engagement. If it's true that policy and technology both have a transformational effect on the direction we go, then to what extent are we prepared to be engaged in the policy making at the state and federal level? This cannot be a spectator activity. This has to be participatory. So resiliency, innovation, collaboration, and engagement. I am absolutely confident that in 2065, as we celebrate the 65th annual summit, we're going to look back with great satisfaction that we've accomplished a good deal. Thank you all very much.
Thank you very much, Senator Daschle. We have some microphones for individuals to ask questions. Don't be shy. Our opening thing was to be engaged. Well, I'll start with one. For telemedicine, you mentioned the VA, you mentioned Kaiser have figured out economic models to support it. Medicare seems to be trailing. What needs to be changed for Medicare to start reimbursing for telemedicine more broadly?
Well, there is a concern, especially in the budget offices of both OMB and CBO, the Congressional Budget Office, that reimbursement, in much the same way we look at reimbursement traditionally, will trigger a far higher level of utilization, and in so doing have fairly significant consequences with regard to the overall budget that I mentioned earlier. I think Ray and I probably share the view that doesn't have to be. First of all, the cost per visit comes down dramatically. The opportunities to access care and provide better environments for wellness may preclude the need to focus on illness. There are so many aspects of this that today aren't fully calculated in the budgetary analysis that troubles me a great deal. But to your question, what needs to be done? Basically, we're going to have to continue to demonstrate, as is now happening in a very small way with CMS, that we can prove fiscal responsibility and even fiscal austerity when it comes to the application of this new technology. I think we're going to get there. We had the same argument really about drugs. There was a huge concern during the debate on Part D whether we were going to see this explosion of drug costs as a result of this new access to drug coverage that we never had before. Actually, we've come in well below what budgetary projections there were, in large measure because many of those predictions were not borne out. And so we have opportunities, I think, to demonstrate budgetary balance and budgetary responsibility, and that's what we're going to need to do. We're migrating in that direction, but a lot of work still needs to be done.
Walter?
Great, Senator. Just maybe in the weeds question, in terms of some of the things you mentioned have at least been approached in the 21st Century Cures Act. I wonder if you have a read on that, and do you think that's a beginning, or do you think do you think it's going to be consequential?
That's a great question, and thanks for asking. I actually am encouraged about the 21st Century Cures Act for three big reasons. First of all, it's almost impossible to find a legislative vehicle dealing with health that enjoys broad bipartisan support today. The SGR repeal about a month ago did that, but 21st Century Cures had overwhelming bipartisan support, and that was so encouraging to me. A recognition, really, that there are a number of issues that we need to get onto, putting all these past vitriolic and combative debates behind us. The second is a recognition of the importance of research. They have been prepared to invest a significant degree in more research and more technology. And that, to me, is half the answer. It's this integration of research, I should say, of policy and technology that provides us with the transformational environment we're going to need to get the job done. So I'm encouraged by that as well. The third thing that encourages me is this recognition of the importance of trying to bring policy into a new era where it's more flexible and less rigid. The 21st Century Cures Act provides much more flexibility. We saw a little bit of that with the ACA, the Affordable Care Act. We see a lot more of it with the Cures Act, providing a policy framework that anticipates the unexpected. And 21st Century Cures does this better than almost any other piece of legislation I've seen in recent times.
We're going to go to Dr. Burke, and then we'll go to Carl. We got a microphone coming.
About the critical importance of research in the future. Yet, real dollars in NIH funding have dropped very significantly.
Well, that may be one of the most important questions we'll be discussing all day long. You're absolutely right. The level of funding for research and NIH in particular has gone way down. The 21st Century Cures Act begins to address it, not as satisfactorily as many of us would like. But as I talked to Francis Collins, he is distraught at how many very exciting and promising research projects go completely unfunded and ultimately die because they don't have adequate resources. And so what can we do? I think it's critical. If there's one thing we as a summit could do, would be to express as loudly and as unequivocally as we can how critical this research really is. Because it's perishable. And that research, if it's not addressed, many times is lost. So we need to bring Congress to an understanding of that. One of the hang-ups that we had with the 21st Century Cures debate was finding the offset. And I will say it, I mean, it probably won't surprise you because of my political past, but if we have to raise revenue to pay for this rather than borrow it, I'm all for it. I think we've got to do whatever it takes to ensure that the research dollars are there.
We'll go to the speed round, the last few minutes. Carl?
Looks like from the numbers you said, Medicare is about 5% of the GDP now, so about 4% of the GDP is on chronic care. And a significant portion of that is spent on Medicare beneficiaries' last 30 days of life. But discussing this end-of-life care has evaded really kind of rational policy and discussion. What do you think the next steps are to actually move that debate forward?
Well, it's going to continue to be difficult. It's so easy to politicize many of these issues, and it has been overly politicized, as probably all of you know, in the last several years. Accusations of death panels and all of this. So we've got to set the record straight, first of all. I think there is a realization that we are facing these dire results unless we begin to address in a more collective and collaborative way the challenges we face around the end of life. And I think providing policy options. Senator Warner from Virginia has offered legislation that would require Medicare to provide a living will opportunity when you become eligible for Medicare as one small way with which to address some of the issues around end of life. I think the way we address the costs associated with end of life treatment also could be reviewed more carefully. I think having some requirement for shared cost commitment is something we ought to look at. Hospice and palliative care, of course, play a very important role. But none of these issues have gotten the attention in large measure because, number one, they are complicated, and number two, they've become very, very combatively political. And we've got to get beyond that, and I think we will. I also think in medical schools that it will be important for us to teach our upcoming physicians that death is not always the enemy. And we do that today. I think it's important for us to look at death differently than we have. I think oftentimes physicians look at death as failure. And I don't think we can afford to do that. I don't think that's necessarily the way we look at the world these days. But that, too, has to be addressed. Thank you.
David?
Senator, thank you for your remarks. One of the comments you made was about the siloed nature of the industry. And in fact, from my vantage point, it looks like it's becoming increasingly siloed as you see more and more competition being infused into the industry. A lot of what's taking place in the development of ACOs and the development of limited and tiered network products, drive in that direction. How do we, at the same time, get the sharing of information, the standardization, which is required to get to reasonable sample size, to get conclusions out of information? How do we deal with that as it becomes more and more competitive?
Well, that's really one of the most perplexing questions we're facing on the regulatory side, especially. I would share your view that it seems, in many respects, we're getting even more siloed and more segregated, and that's very, very troubling. I've always maintained that our healthcare sector could never really be described as a so-called system if you consider a system as having a central decision-making or a central administrative authority. We don't have one. And I think it's unlikely we'll ever have one, at least in the foreseeable future. So without a system, we have what I call a collage of subsystems. And this collage oftentimes offers strengths in innovation, but a lot of weaknesses in segregation and siloing. So we've got to look at how we're going to create an opportunity for greater collaboration in this collage of subsystems. And I think what we need is a framework. It's controversial, but I spent a lot of time in both of my books that I wrote over the last few years on health, talking about having a Federal Reserve framework that allows for far greater collaboration and systemic integration than we have today. Chances of that occurring anytime in the near future are slim to none. Even IPAB, a very small, maybe 1% of the whole spectrum, is the source of enormous controversy in Washington today. But that, to me, is the ultimate way to create that framework to allow integration in a more meaningful way in a non-systemic environment.
Last two questions. Speed round. Jim.
Senator Daschle, thank you for coming. My question is that the industry seems to be moving quite quickly from a professional-dominated model to business to consumer, to a model now where the consumers are really starting to take over and to drive what's happening, both on technology and user. You could say part of that is the increased copay, increased deducts, things like that. But I was wondering what your thoughts on that, and I see that as ultimately a good process, and I was wondering what your thoughts are on perhaps enabling that process to continue or even accelerate more freely.
Well, I share your view, and I think we're just getting started. I think consumers are going to play a far greater role, whether it's electronic health records, access to transparency and quality data alone will change the landscape significantly. There are companies that are creating business models around greater transparency. Gaslight is a good example. So I think we'll see this transformation occurring at all levels. And I think what we have to do is to accelerate it, yes, but make sure that we have the ability to empower consumers to make good decisions. We all have far greater access to information today than we've ever had, but I'm not sure that it's advanced the quality of our decision making, especially at the legislative level. And so we have some real challenges here in making sure that we can channel this new information and these new empowered tools to accomplish what it is we're trying to do. But the environment is rich and the opportunities are there. But I think it's going to take a lot more thought to determine how we can make sure that we maximize the value of these new tools in the next couple of years.
Thank you. Bruce, last word.
Hi, Bruce Leff, geriatrician from Baltimore. So we don't do quite as good a job as integrating social services with medical services compared to a lot of other countries that seem to do a better job of keeping costs down. I was just wondering if you had any thoughts about policy, about how to push that forward.
I agree completely. The whole issue of nutrition especially is one that's only beginning to become more connected, I think, with health. If you look at diabetes and the connection with obesity, you've got a perfect illustration of the need to bring nutrition and larger health issues into proper context. And that's why I think this whole notion of moving from illness to wellness and to recognize that wellness goes beyond the narrow confines of health delivery or health consumption is really essential. I especially think that's true in the early stages of life, where children in particular need the nutritional opportunities that sometimes they're not provided. And if we can put them on the best nutritional track and a track that allows them to take care of themselves more effectively and recognize the importance of their physical responsibilities as well, then the health will come easier as time goes on. But we haven't made that connection nearly as well as we should. I'm encouraged. We're beginning to make some real progress in that regard. I just was in a long meeting yesterday with an organization, a new coalition that's beginning to make that as their central goal. So while progress is there, we're we're still virtually on the starting line.
Please join me in thanking Senator Daschle
Thank
not
you all
only
very
for an
much. I
outstanding
enjoyed it.
presentation,
Thank you.